today, we are plunging into the terrifying, but honestly, clinically fascinating world of seizure emergencies.
It is the absolute definition of diagnostic muddy waters. Primarily because the brain's electrical activity is invisible to the naked eye. When those signals go off script, it's a high stakes guessing game unless you know exactly what to look for.
Right, and our guide for this journey is a comprehensive evidence-based review. It's titled First Seizures, Acute Repetitive Seizures, and Status Epilepticus.
Yes, by Dr. David G. Vossler.
Exactly. Featured in the February 2025 issue of the Continuum Neurology Journal. And we are going to track the escalation of these brain emergencies, starting with a single unexpected electrical storm, then moving to cyclic clusters, and finally exploring what happens when the brain's off switch just completely breaks down.
Dr. Vossler's review is really a remarkable synthesis of where emergency neurology stands today. The overarching theme you'll notice is that time is literally brain tissue.
Time is brain tissue. I like that phrasing.
Yeah, knowing when to intervene and precisely how much medication to use, it dictates whether a patient recovers fully or, unfortunately, suffers permanent neurological damage.
So, okay, let's unpack this. Let's start at the very beginning of the clinical pathway. The first strike. A patient experiences an unprovoked seizure for the very first time. Because I think the average person might view a single seizure as, a freak occurrence, like a glitch that happens once, you shake it off and you move on. Is that how neurologists view it?
Not at all, no.
Yeah.
A first seizure is a major life-altering medical event. Dr. Vossler highlights this massive study tracking long-term outcomes, and it reveals an overall hazard ratio of 3.06 for death in the years following a first seizure.
Wait, really? 3.06?
Yes. And to translate that statistical jargon into human terms, experiencing one unprovoked seizure triples your baseline risk of mortality. It equates to approximately 10 years of potential life lost over your lifespan.
10 years of life lost from just one event.
Yeah, it's sobering.
That instantly changes how you look at a single seizure. But what about the immediate future? Like, if I have one seizure, what are the actual odds that my brain is going to do it again?
Well, the risk is heavily front-loaded. On average, there is a 36% chance of a second seizure within 2 years. And then that climbs to 46% at 5 years.
Nearly half.
Right. But those are just baseline averages. The risk effectively doubles if you present with certain clinical red flags.
Okay, what kind of red flags?
Mostly abnormalities on your initial tests. So if an EEG, which measures your brain waves, shows epileptiform discharges.
Which are what, exactly?
They're these sharp spikes of electricity that indicate the brain is primed to seize again. Or, if a brain scan reveals structural damage, like a scar from a prior head trauma.
Ah, okay, that makes sense.
And curiously, even the timing of the first seizure matters. Like if it occurred while you were asleep, your risk of recurrence is significantly higher.
That is fascinating. But I'm looking at Dr. Vossler's review regarding how doctors treat that first seizure, and I'm honestly a bit confused by the dilemma it presents.
It's a tough one.
Yeah, because it says giving anti-seizure medications right away reduces the risk of a second seizure within the first 2 years. That makes sense. But then it explicitly notes that early treatment doesn't actually improve the long-term chances of sustained seizure remission over the span of the patient's life.
This raises an important question, right? That is the core tension in the exam room. You are constantly weighing immediate protection against long-term realities.
But wait, if giving the medication right away doesn't cure the underlying long-term problem, isn't that just like putting a brace on a twisted ankle?
How do you mean?
Like it stops the ankle from hurting right now, it prevents you from rolling it again today, but it doesn't fix the underlying weakness in the joint. Why should a patient risk all the daily drug side effects? The fatigue, the mood changes, the organ strain, if their 10-year outcome is going to be exactly the same?
Your ankle brace analogy hits the nail on the head, actually. The reason you still might want that brace is to prevent a catastrophic secondary injury.
Oh, like falling.
Exactly. A second seizure isn't just a neurological inconvenience. It could happen while you're driving down the highway, or swimming in a pool, or walking down a flight of stairs.
That is a terrifying thought.
Right. So the immediate protective benefit is really about preventing physical trauma, not to mention the psychological terror of constantly fearing the next episode.
So how does a doctor help a patient make that choice? It feels like an impossible coin flip.
Well, medicine is increasingly turning to artificial intelligence frameworks for this, specifically something called the Markov decision model.
AI is helping with this.
Yes. Mm-hmm. Instead of waiting decades to see how thousands of patients fare in real life, researchers use the Markov model to simulate complex clinical trials. It runs thousands of simulated lifetimes, comparing immediate treatment versus waiting for a second seizure.
Wow.
Yeah, it calculates variables to maximize what we call quality adjusted life years. So this tool allows a doctor to sit with a patient and say, based on millions of data points tailored to your specific age and health, here's the mathematical balance between the risk of medication side effects and the risk of a recurrent seizure.
That is wild. AI is simulating entire lifetimes just to help us make a single choice in a clinic.
It's revolutionary.
But okay, let's assume the preventative measures fail, or the patient chooses to wait, and the electrical storms return. But they don't just return as single events, they start compounding on each other.
Yes. This brings us to the territory of acute repetitive seizures, which are often called cluster seizures.
Right, and the review mentions these clusters often operate on infradian cycles. I actually had to look that up.
It's not a common term outside of chronobiology.
Yeah, it means a cycle that lasts longer than 24 hours. So we are talking about multi-day or even monthly rhythms. The brain doesn't just fire off randomly, it falls into a dangerous groove.
Recognizing that rhythm is the key to managing epilepsy. Many patients have a known baseline pattern. Maybe they have one seizure every few months. An emergency is when they break that pattern and cluster.
What causes them to break the pattern?
The triggers are incredibly common. Forgetting to take their daily medication, severe sleep deprivation, a spike in alcohol use, an underlying viral illness, or even hormonal shifts during a menstrual cycle.
Okay, so if a patient feels a cluster starting, my first instinct would be to just swallow an extra dose of their daily oral medication. Just take a pill and head it off.
That is a very common instinct.
But Dr. Vossler's review explicitly warns against relying on standard oral pills in an emergency. Why is that?
Because of human anatomy. Standard oral medications take 60 to 90 minutes to reach their maximum concentration in the bloodstream.
Oh, wow. An hour and a half.
At least. When you swallow a pill, it doesn't just dissolve in your stomach and magically teleport to your brain. It has to survive stomach acid, pass into the jejunum, which is the middle section of your small intestine, and then be absorbed through the intestinal wall into the blood.
That is a long journey.
And if you just ate a meal, that digestion process is delayed even further. In a seizure emergency, a 90-minute delay allows irreversible brain damage to occur.
Right, it's like trying to put out a fast-spreading kitchen fire with a slow-dripping faucet. You can't wait for the digestive tract to process a pill. You need the fire extinguisher right now. So what do doctors use instead?
Rescue medications that bypass the digestive system entirely. We rely on mucosal absorption or intramuscular delivery.
Okay, so sprays and shots.
Exactly. We use intranasal sprays of diazepam or midazolam, rectal gels, or an autoinjector straight into the muscle. These areas are incredibly dense with blood vessels, allowing the medication to hit the bloodstream and cross into the brain almost immediately.
But if the goal is to stop the electrical fire as fast as possible, can't we just give them a massive, overwhelming dose of these nasal sprays just to be safe?
Absolutely not. The pharmacology here is unforgiving. Rescue doses must be strictly weight and age-based. For example, diazepam dosing tops out at 20 milligrams for an adult.
So why is underdosing highlighted in the text as a massive failure point in clinical settings?
If we connect this to the bigger picture, if a caregiver or medical professional is too timid with the dose, the medication simply won't reach the required threshold concentration in the brain to halt the misfiring neurons.
It just doesn't work.
Right. The cluster will literally break right through the weak medication barrier and progress into a full-blown, life-threatening emergency.
Which brings us to the most critical phase of all. If that cluster isn't stopped, the patient enters status epilepticus. This condition seems to be governed by incredibly strict biological clocks.
Yes. Status epilepticus, or SE, is the ultimate failure of the brain's internal off switches.
The off switches just break.
Essentially, normally the brain deploys inhibitory chemicals to terminate a seizure within a minute or two. In SE, those inhibitory mechanisms exhaust themselves, and excitatory chemicals take over, locking the brain in a continuous loop.
And there are specific times to watch for, right?
Yes. The International League Against Epilepsy defines two critical time thresholds here, T1 and T2.
Okay, so T1 is the 5-minute mark for a convulsive seizure. If someone is convulsing for 5 minutes, the guidelines dictate that therapy must begin instantly.
Immediately, yeah.
Then there is T2, the 30-minute mark. Why is 30 minutes the magic number? What physically breaks down in the brain at that point?
At 30 minutes, the brain is consuming so much energy and oxygen to fuel the seizure that it literally starves itself.
It's burning through its own fuel.
Exactly. And simultaneously, the continuous firing floods the brain with excitatory neurotransmitters like glutamate, which become toxic at high levels.
Yeah.
You start seeing widespread neuronal death. The actual physical networks of the brain begin to warp and alter.
That's terrifying.
It is. That is why hitting the T1 5-minute clock with phase 1 treatments is so aggressive.
Right. And phase 1 treatments are full, heavy doses of benzodiazepines. We are talking IV lorazepam, IM midazolam, or IV diazepam.
Yes, the heavy hitters.
But okay, here's where it gets really interesting. I need to push back on this because I am looking at these drugs and they are profound sedatives. Aren't doctors terrified of suppressing the patient's breathing? Giving a massive dose of sedatives to someone already in a medical crisis seems counterintuitive.
What's fascinating here is you have just highlighted one of the most tragic ironies in emergency neurology. The fear you just described is exactly why doctors in clinical practice often underdose phase 1 drugs.
Wait, they underdose out of fear of stopping the breathing.
Exactly. The psychology of the provider gets in the way of the biology of the disease. It is true that benzodiazepines suppress respiratory drive, but a brain locked in a generalized convulsive seizure is not sending coordinated signals to the lungs anyway.
Oh, so they aren't breathing well to begin with.
Right. The airway is already compromised, the oxygen demand is through the roof, and the patient is suffocating. Uncontrolled status epilepticus is far more likely to cause fatal respiratory depression than the properly dosed drugs themselves.
I see. The seizure is what's stopping the breathing. You have to put the fire out before you worry about water damage from the fire hose.
Beautifully put, yes.
Yeah.
And understanding how these specific drugs work is crucial. Take diazepam, for example. It is highly lipid soluble, meaning it dissolves easily in fats.
Okay, why does that matter for the brain?
Because the blood-brain barrier is rich in lipids, diazepam slips right through and starts shutting down the seizure almost instantly.
But there is a massive catch with lipid-soluble drugs, isn't there?
A very significant one. Because it dissolves so well in fat, it refuses to stay in the brain. It rapidly redistributes out of the brain tissue and hides in the body's peripheral fat stores.
Oh, wow. So it just leaves.
Exactly.
Yeah.
So your therapeutic window, the time it is actually suppressing the seizure, is very short, sometimes just an hour or two. You have to hit the seizure hard with a full dose before the drug washes out of the brain.
And if that phase 1 strike doesn't work, we move to phase 2. Dr. Vossler mentions a landmark clinical trial called the ESET study.
Yes, a very important study.
They tested 3 major 5E drugs: fosphenytoin, valproic acid, and levetiracetam.
What are these drugs actually doing that a sedative doesn't?
Well, instead of just generally sedating the brain, phase 2 drugs actively interfere with the cellular mechanics of a seizure.
Like getting into the gears of it.
Precisely. Fosphenytoin, for example, physically blocks the sodium channels on the outside of the neurons, which prevents them from firing those rapid electrical signals.
I assume the ESET study would crown one clear winner among those 3, like one miracle drug. Many people did, but the results proved they are all equally effective, stopping the status epilepticus in roughly 45 to 47% of cases.
Which is great for hospital stocking, I guess, but it leaves a terrifying reality. Over half of these patients will keep seizing despite phase 1 and phase 2 drugs.
And that failure pushes us into the deep end. We have to look at what happens when the violent convulsions stop, but the brain keeps seizing anyway.
Non-convulsive status epilepticus. This is just baffling to me. How do doctors even spot a seizure if the patient isn't shaking? If someone is just lying there unconscious in a hospital bed, how do you know their brain is locked in an electrical storm versus them just being in a normal coma?
It is arguably the greatest challenge in the emergency room. Non-convulsive SE has practically no motor signs.
So what do they look like?
The patient might just look confused, or stare blankly, or be completely unresponsive. And because it is practically invisible, the median time to treatment is a staggering 150 minutes.
150 minutes.
Yes. Remember that 30-minute T2 clock where brain damage starts? These patients are sitting in a seizure for 2.5 hours before anyone realizes it.
And the statistical fallout from that delay is brutal. The review states that a misdiagnosis carries an odds ratio of 3.83 for the patient never returning to their functional baseline.
It's devastating.
Meaning they are nearly 4 times more likely to wake up with permanent, life-altering brain damage. So how do doctors eventually, see it?
They rely on the Salzburg EEG criteria. They urgently connect the patient to continuous video EEG monitors. The EEG becomes their eyes into the brain.
And what does that look like on the screen?
Instead of normal, calm brain waves, the monitor will show rhythmic delta theta waves, which look like these tall, crashing ocean waves of electricity, or continuous sharp spikes that indicate the brain is constantly misfiring.
When you finally see those spikes, and you know phase 1 and phase 2 drugs have already failed, the patient has officially entered refractory status epilepticus. The guidelines say you have to bring out the continuous IV infusions. Are they literally putting the patient into an anesthetizing coma?
Yes, they are. They use continuous drips of drugs like ketamine, propofol, or pentobarbital.
How does forcing someone into a coma stop a seizure?
Well, it is the ultimate blunt force instrument. Anesthetic comas broadly suppress the entire central nervous system. They force the metabolic demand of the brain to plummet.
Just shutting the whole factory down.
Exactly. They strip away all background electrical activity until the brain is essentially flatlined, hoping that taking the whole system offline will finally starve the seizure circuit of the energy it needs to keep looping.
But what if this happens to someone who has never had a seizure in their life? This brings us to a subcategory in the review that genuinely gave me pause. Norse.
Yes, new onset refractory status epilepticus.
It sounds like a nightmare.
It is one of the most frightening phenomena in neurology. Norse hits patients with absolutely zero history of epilepsy. A perfectly healthy adult or child goes to sleep and they wake up locked in a refractory electrical storm that won't stop.
How is that even possible? Does the review know what causes it?
It is often cryptogenic, meaning the root cause remains completely hidden despite exhaustive testing. We just don't know.
Wow.
However, there is a specific subcategory called FIRES, febrile infection-related epilepsy syndrome. In FIRES, the patient usually had a mild, completely routine fever or viral infection a few weeks prior.
Wait, a mild fever causes endless seizures weeks later.
The prevailing theory is an explosive, delayed autoimmune response.
Oh, I see.
The immune system clears the mild virus, but then hyperactivates, crosses into the brain, and triggers a massive inflammatory firestorm that irritates the neurons into a continuous seizure.
And because it is driven by inflammation, traditional seizure drugs rarely work, right?
Exactly. Dr. Vossler's guidelines stress implementing severe immunotherapy within the first 72 hours, blasting the immune system with high-dose corticosteroids or IV immunoglobulins. They even use strict ketogenic diets.
What, the keto diet, like the low-carb fat? How does eating fat stop an autoimmune seizure?
It's fascinating, actually. When you strip carbohydrates entirely from the diet, the brain is forced to stop using glucose for fuel and switch to burning ketone bodies.
Okay.
This metabolic shift drastically alters the biochemical environment of the brain, increasing the production of calming neurotransmitters and actively reducing cellular inflammation. It's basically a metabolic hack to put out the fire.
Well, what if even that fails? The coma, the immunotherapy, the diet. What happens when every tool in modern medicine just doesn't work?
Then you enter superrefractory status epilepticus. This is defined as seizures that persist or return even after a full 24 hours of profound general anesthesia.
Even under anesthesia?
Yes. The resilience of the disease at this stage is staggering.
The numbers are devastating. The mean duration of superrefractory SE is 36.3 days. Let that sink in. Despite being in a medically induced coma, the brain fights a continuous electrical fire for over a month.
It's grueling for the patient and the family.
And the mortality rate is 24%, and only 26% of patients leave the hospital with 0 to slight disability. You mentioned earlier that the brain alters itself physically at the 30-minute mark. What does a brain look like after 36 days of this?
We can see the devastation clearly on MRI scans. The constant electrical bombardment causes the tissue to swell and physically warp.
Where in the brain specifically?
The review notes massive abnormalities in the cerebral cortex, the thalamus, and the hippocampus. And these aren't just random areas. The thalamus is the brain's central relay station for consciousness and sensory processing.
And the hippocampus is memory, right?
The absolute core of human memory formation, yes. The very structures that make the patient who they are undergo structural siege.
It is a stark, humbling reminder of how fragile these electrical loops are. We have covered an immense amount of ground today. From the predictive AI models doctors use to map the risks of a single first-time seizure, to understanding why the jejunum delay makes oral pills useless for multi-day clusters.
All the way to the desperate race against the 5-minute and 30-minute clocks in status epilepticus.
Exactly. It is a profound journey through the escalation of a true emergency.
It really underscores why the exact weight-based dosing of rescue medications and the urgent deployment of continuous EEGs are non-negotiable standards of care.
So, what does this all mean for you listening to this deep dive? I want to leave you with a final, thought-provoking idea to ponder. Consider the terrifying, delicate balance of the human brain. The exact same electrical mechanisms, the exact same neural pathways that allow you to think, to feel love, to recall a childhood memory, or dream at night, they can suddenly get locked into an infinite self-destructive loop.
It's a fragile system.
But as artificial intelligence, like the Markov models we discussed, continues to evolve, mapping these electrical storms with unprecedented precision, will we eventually find a way to proactively reboot the brain before that 5-minute clock even starts? Could the future of neurology look less like fighting a massive fire and more like rewriting the electrical code before the spark ever catches?
It is a fascinating frontier, and given how much is at stake, it cannot arrive soon enough.
Thank you for joining us on this intense, custom-tailored deep dive into Dr. Vossler's research. Picture of the brain's electrical systems might still be murky, but the science working to clear those waters is nothing short of brilliant. Until next time.